Thank you, organizers, for giving this opportunity to share my views regarding subarachnoid hemorrhages. I have no conflicts of interest, but we now discovered the importance of AI, and that's a fantastic opportunity to actually solve a lot of issues we have in medicine. So we're now able to replicate by computing the integration process of an artificial neuron and integrate those neurons into neural networks. And what we try to do is creating what we call virtual twins in health, meaning aggregating the knowledge we're generating, modeling it into networks, and making so that we can use those networks to properly manage patients, to actually decide on treatments and predict outcomes. Now, myself, I'm fully aware that I have biases. And those biases are coming from the literature I had access to. And I didn't read everything, and I didn't enjoy reading everything. I'm not aware of all the studies, but I have a selection of ongoing studies I follow because I'm interested in. And I have my networks that give me information. And I have my personal experience where I ground myself on my everyday exploration of the disease. And that's also impacted by my human cognitive biases. I know that I have things that are more interesting or easier, and I may be deforming the reality just to please myself. So what I'm going to do today is showing you a map of my understanding today of the subarachnoid hemorrhage disease and my understanding of its management and how we can progress in the future to improve that management. As an overview, I will start going through the latest guidelines on the management of subarachnoid hemorrhage that were published in 2023. This all about standards, standard operating procedures, tools, and going through the toolbox we have to improve the management of or to take care of our patients. I will then shortly discuss about, I think, the game changer lately, which is the early drain study that demonstrated that setting early a lumbar drain actually reduces the risk of vasospasm and has a potential good impact on the patient outcomes. I will go through my vision and my understanding of my also guidelines or visions about how to best use the monitoring tools. And give my view regarding how we can use AI and how we could actually provide information to AI to actually improve the modeling and improve our decision making. And that requires that we connect what we see as surrogate factors in clinic to principal factors of the disease, and that we use for that biomechanical modeling, physics, logics, mathematics. We have to find ways to increase the precision of our assessments, definitely. And we have also to look at how we can control for biases and better use real-world data. And that requires the integration of the FAIR principle, that data is findable, accessible, interoperable, and reusable, and that we also, as doctors, have some understanding of what semantic is. The latest guideline, well, the latest guideline, they go through the whole itinerary of the patient, starting with the initial management, which I would summarize as aiming for physiological conditions, thinking about withdrawal in extreme cases with a high WFNS and brainstem dysfunctions. Patients should be taken care of in high volume centers. And what a high volume center is should be adapted for Switzerland. And the aim is to actually completely exclude the aneurysm that bled within less than 24 hours. How should the aneurysm be secured? That's a very long discussion, and I'm not going to enter into it. And I think I'll be summarizing that that's an expert decision of a team of colleagues, which are collaborating for the best of the patient. Anesthesia, you see there is not much of green. There is a lot of yellow and orange. There is one red, no hypothermia. And I think here I can summarize that as actively aiming for physiological conditions, but on the high sodium side. In the ICU, well, there's some green, a little bit of yellow, and one red. And I can summarize that as Neurointensive Care unit should actually aim at reducing the ventilation duration. They should keep the people euvolemic. They should neuromonitor and have very quick reactions when there are changes on the neuromonitoring. And that requires to have care protocols, to have trained staff, and to have certified centers. And if I look at neuromonitoring, there are many biomarkers and there are many levels. And if it's numbered from 1 to 5, means that there are causal factors that actually induce effects. And this is chaining. And I'm a strong believer that if you want to be very effective, you need to keep your buffers and you need to act as early as possible on the most upstream factors, meaning that I have a very strong interest into autoregulation, and that we now have a very good interest into continuous EEG, because that allows us to understand what causes and to actually look at the reactions and very quickly understand how the tissue is reacting to the cause. So we really want to have a closed loop on the causal effect relationship. And that requires that we have a very systematic view integration of the different modalities in an integration monitoring system. And I think we should really think about as pilots to have a standardized display. So when we go from one institution to another, we're facing our instrument in a similar place. So we can actually, as humans, integrate that information and quickly know where things are and get patterns in our minds that make our decision making easy. So I think we should organize ourselves not only to look at the factors we monitor, but also at the way we display in a very ergonomic way and a standard way that makes that when we travel from one institution to another, we don't have to learn again all the experience we acquired so far. Hydrocephalus is actually, for me, getting simpler because we put a lumbar drain on every patient. And we actually put an EVD when there is a non-communicating hydrocephalus and there is an effect on the consciousness level. And we actually then remove that EVD and the patient has still an hydrocephalus. We put VP shunts very easily. Vasospasm, while early drain is the game changers, we had nimodipine and nibotipine remain. So I can summarize that: early drain, nimodipine, euvolemia, and now we know no statins, no magnesium, no prophylactic high blood pressure. Epilepsy. Well, here we now know that there is no phenytoin, no routine prophylaxis, but we advocate continuous EEG. And if there is a fit, if there is some epilepsy, well, we should treat for a duration of 7 days and reassess. If we look now downstream on the recovery of ASAH, well, here what is very obvious, and there is a lot of very high evidence demonstrate that we have to monitor our patients, and we need to monitor cognition, we need to monitor psycho, anxiety, depression, quality of life, and we need to follow up with imaging to look for regrowth and repermeabilization. So to apply those rules or to apply those guidelines is really now a challenge in precision medicine. And we have that issue of framing biases, that we only remember what we select. We make those assumptions regarding the factors and consider that the factors are all independently acting on the outcome, but they're not. So we have to be finding ways to see how those different factors do interact. And that is by actually understanding the mechanisms behind. So for me, it's extremely important to understand the mechanisms behind the disease and actually connect the surrogate factors we can see with the principal factors, which are hidden. And that requires modeling. We also need to be improving our granularity of refinement and the precision of how we measure things using better tools. And we then have to share the data, and that is difficult because we have very heterogeneous data. So we actually need to get that all standardized. And we need to do that because we need to work together, because each center doesn't acquire experience fast enough. So we need to actually pool our information to get power to actually be more precise in our prediction and in our modeling. We have tools to actually aggregate data from multiple sources and organize them to actually get from surrogate to principal factors. We're working on that. We have graphs and all the links between the graphs. We're trying to add some equations to formalize the relationships between those different factors. So to give you an example here with the subarachnoid space and subarachnoid hemorrhage, we have a structure, the subarachnoid space, which has trabeculates, and not everyone is aware that there are trabeculates, and actually there are cisterns. And then when it ruptures, it might fill a cistern, it might progress to a different cistern. And here we have this correlation between the amount of blood and the clinical effect it has on the clinical status. We can quantify with the WFNS. And then we have the Fisher grade radiologically, which quantifies the amount of blood. And that is actually a very good predictor of the probability of death and the probability of disabilities, but with huge interval of confidence, because those factors are not principal factors. So here what we do is we need to make a model of the intradural physics, and so we add to the structure in the injury the reaction, and the reaction is actually a displacement of fluid, and that's the Monro-Kelly that went from Monro-Kelly original model to the Monro-Kelly 4 model that now integrates also the displacement of interstitial fluid, very recently ended into this Cambridge model. And what is very interesting is actually we can actually act on that by using flow-controlled ventilation in negative pressure, which actually allows to optimize the motions of fluid into the body, and that actually decreases ICP and increases the PbO2, and it has a big impact on the CPP. So mechanical ventilation with flow-controlled negative ventilation, negative pressure ventilation might be actually a tool we could use in patients. Autoregulation. It's clear that we need to better assess autoregulation, and we need to be able to simulate or to actually identify the optimal perfusion pressure of a patient. Now, we discussed about the subarachnoid space. We discussed about the shifting of fluids to actually keep the intracranial pressure and the CCPP optimal. Now, there is a big effort to actually interconnect the heart, vessel, capillary flow, blood models that are existing, and all couple them together to be able to have a model that across scales allows of oxygen in the tissue, which is actually going to be the principal factor of life and death of a cell. And here we are now able to have a map of the oxygen tension in the tissue in 3D, according to variations of various parameters and even lesions in thoughts. And here I really encourage you to look at the work of Stephen Payne and his group in Oxford in Taiwan, which are massively and aggressively progressing on the topic. So what's our role of clinician? We are not able to do all those models. We are not mathematicians. We're not biologists. But what we can do is assess our patients more precisely. We can collaborate across different institutions to provide more data to actually see how well things are generalizable. And we can then feed feedback and expert opinion and clinical trials to actually get a better collaboration, more connection between surrogate to principal factors. The current map of the aneurysm disease we have in our Gemini consortium, which is looking at the virtual twin of aneurysm disease and stroke. And we have semantic LLMs that are exploring to make the mapping. We have now defined directional acyclic graphs. And this is a representation of the map we are looking for to progressively document with more distribution of cases and making those maps so you can interact with to actually visualize how the factors are interconnected, interdependent, and how they have an effect on the outcome. Thank you very much.